Dear viewers, I'm Dr. Rakesh Gupta. I'm President Cypher and former Director at Services Punjab. So Dr. Texas Clinshots is here with the new episode on sepsis, but is really new. We welcome you all for the video presentation by Dr. Harsimran Walia. He is an Assistant Professor, Department for Anesthesia, Critical Care and Pain, Homi Bhabha Cancer Hospital and Research Center, which is a new unit of Tata Memorial Center in Medicity, Mullanpur, which is a new Chandigarh, and Homi Bhabha Cancer Hospital, Sangrur, Punjab. So we welcome you, sir.
Thank you.
So Dr. Harsimran Walia, as I told you, he is Assistant Professor in Department of Anesthesia, Critical Care, and his institute is well known all over the country. And he's qualified as MD Anesthesia. He's an Indian Diploma in Critical Care Medicine from Fortis Hospital, Mohali. And he's also a fellow of Critical Care Medicine from SPS Apollo Hospital. He has given various presentations as faculty and Anesthesia Review Course, ARC, Research Society of Anesthesiology, and is member of various societies of his specialization. And his special area of interest is antibiotic stewardship, sepsis, end-of-life care, point of care, ultrasound and ICU, advanced hemodynamic monitoring. So we welcome you, Dr. Harsimran.
Thank you so much.
You may just carry on with the presentation.
Hello to all. So today we will be talking about sepsis, what is really new. So what we understand about sepsis, how the guidelines have changed, what we perceive about the fluid resuscitation, the antibiotics, so where we stand right now. So we will be talking in detail about sepsis and where we stand right now with our guidelines, what we really need to do when we encounter a patient of sepsis, and that we do quite frequently in our ICUs. So let's kickstart our presentation. So I will start with the history part. So sepsis, if we see, it dates back way back in 1860s when Louis Pasteur gave the credence to germ theory, when he said that the food that is getting spoiled by the microorganisms that are invisible. So the culprit was then identified that these microorganisms that can be bacterial, they are invisible to the human naked eye. Then 1890 was Robert Koch postulated a state of disease every disease has a positive organism. Then in 1992, first definition of sepsis came into being. So this was first identified in 1992. We called it as sepsis 1. Then the very famous trial that changed it all came into existence in 2001, done by Rivers et al., where he published the early goal-directed therapy. So these guidelines, this trial was very early incorporated in 2002 in sepsis 2 guidelines, and then came into existence the surviving sepsis guidelines, the very famous surviving sepsis guidelines. So they came into being in 2004 by Dillinger et al., just for an effort to reduce the mortality of sepsis, because in 2000s, before 2000s, the mortality of sepsis was as high as 50 to 60%. Means every patient landing in sepsis in ICU, every second patient was dying. So that was the need for the surviving sepsis guidelines that came into being in 2004. Then again in 8, 12, 16, and now the latest update has come in 2021. So we will go through a bit of history as well when we progress. So why we worry about sepsis? Why we want to talk about sepsis? So as you can see, the incidence of sepsis, 31.5 million cases of sepsis are there. And overall mortality of sepsis in ICU is now around 26-27%. And mortality of ICU treated sepsis is 42%. And if we talk about Indian data of ICUs, the INDICAP2, very famous INDICAP2 study that was conducted and concluded in 2021 also said that incidence of sepsis was around 50%. And our mortality is not less globally as well. So our mortality is very high, around 25-30% mortality in Indian ICU scenario as well. So where does India stand? If we see, India again is red hot here also, because sepsis incidence is very high in India. So we'll start with a case. So what normally we see in ICUs. So this is a normal presentation we see day in and day out. A 77-year-old man presenting to emergency department with history of fever and cough. He is drowsy and confused as well. So the systemic arterial blood pressure is 100/50 and heart rate around 98 beats per minute with respiratory rate of 25. So can we say this patient is in sepsis? Is this sepsis or not? So this we'll see in our presentation. So what are the definitions, what are the guidelines, how we define sepsis, and how to go about it. So again, flashing back, sepsis 1 came into being in 1992. So it just said that if the patient has infection plus SIRS. SIRS is systemic inflammatory response syndrome. So if this is present, we call the patient has sepsis. And to call the patient has SIRS, there was a criteria that is called as SIRS criteria. So they had 4 parameters. Any 2 out of 4, if they were positive, we called that patient had SIRS. That patient has inflammation. And we all know sepsis is about inflammation. So the criteria were temperature of more than 38 degrees or less than 36. That is both hyperthermia as well as hypothermia. A patient having heart rate of more than 90 beats per minute, respiratory rate of more than 20 per minute, and WBC counts either less than 4,000 or more than 12,000 qualified for this criteria. So then came sepsis 2 guidelines that came in 2001. So actually that time they didn't change much because they didn't have any advances in that sepsis. But the criteria were elaborated of leukopenia, leukocytosis, the hemodynamic parameters they increased. But what they came into conclusion was, there is lack of evidence to challenge that they have lack of evidence to challenge the existing sepsis definition, and there was no addition to the existing definition. Then finally came sepsis 3. This definition changed it all. It incorporated new definition for sepsis. It came in 2016, and we are still using the same definition that was given in 2016. So what did it say? So the definition change now was sepsis was identified as life-threatening organ dysfunction caused by dysregulated host response to infection. So now we have recognized it is a life-threatening thing and it causes organ dysfunction, and the response is not regulated as it should be. And once the response becomes dysregulated, we call it as sepsis. Now, septic shock, severe sepsis was born in 2016 guidelines. Septic shock was now identified as a subset of sepsis in which there was circulatory, cellular or metabolic abnormalities as associated with greater risk of mortality than with sepsis alone. So being a subset, it had a higher mortality and was recognized if the patient had a blood pressure or mean arterial pressure of less than 65 and serum lactates of more than 2 millimoles per liter in the absence of hypovolemia. So this was the criteria that patient should be adequately volume resuscitated, mean arterial pressure should be less than 65, or requirement of vasopressors to increase mean arterial pressure beyond 65. And if you do an ABG, the lactate should be more than 2 millimoles per liter. So this was the change in the definition. Now, again, we have seen this septic shock is again requirement of vasopressors and lactates of more than 2 millimoles per liter in the absence of hypovolemia. This is important. So we should adequately first resuscitate the patient with fluids. Now, in sepsis 3, the making of diagnosis, there was an introduction of SOFA score. So SOFA is sequential organ functional assessment score, and organ dysfunction, they called it as identified being score more than 2 points change if there is an infection, provided we have a baseline SOFA score, and baseline is assumed to be 0 if patient does not have any other comorbidities. So SOFA, how do we see SOFA score? So we have 6 parameters. We look at the respiration, we look at the coagulation, the liver profile, the cardiovascular state, the CNS as well as renal profile. In respiration, we look at the respiratory parameters like how is the gas exchange, what is the PaO2 FiO2 ratio that we normally see? If it is more than 400, 200 to 300, 100 to 200, or if patient is in ARDS, we give numbers according to the same. Coagulation, we look at the platelets. More than 1.5 lakhs, less than 1.5, so we give numbers according to the same. In liver, we look at the bilirubin values. The values have been given. Cardiovascular, we look at the hypotension or requirement of a vasopressors. In CNS, we just look at the GCS, whether 15, less than 15. And in renal, we look at the creatinine values. So if it is less than 1.2, we give 0 number, 1.2 to 1.9, 1, 2 to 3.42, 3.5 to 4.9 is 3, and in end-stage renal disease, we give 4. So this was a actually cumbersome process to carry out for every patient. You need a calculator for the same. So what they did was, rather than calculating it, they introduced what it is called as quick SOFA, quick assessment of the sequential function of a patient. So here only we look at the three things. So that is the mental status, the respiratory rate, and the systolic blood pressure. If 2 are positive, we called it as the patient has an increased chances of having sepsis. The quick SOFA score. And the mnemonic was HAD. Hypotension, altered mental status, and tachypnea. So very easy to remember as well, HAD. So, but it came into vogue in 2016, but the recent guidelines that have come up in 2021, now they suggest that you cannot only use quick SOFA. It is not superior to the search that were initially using, or NEWS, that is National Early Warning Score, that we were initially using. So both they have validated, all the scores they have validated equally. So they were preference for quick SOFA, but it is not, there is no further preference for quick SOFA. You can use it, but you can use search as well as NEWS score as well. So now talking about 2021 guidelines that we see, what they have to say about fluid sepsis, their definition, what changes they have brought. So we'll quickly sail through the 2021 guidelines. What are the recent changes in management of patient with sepsis? So treatment has evolved over the years. We were struggling initially. Now treatment has evolved over the years. And see how we manage our patient with sepsis and septic shock. So for this part, I will like to give the headings to my talk with initial resuscitation and fluid therapy, how we diagnose our patient, how we give antibiotics. Obviously, source control is very important. If their patients require mechanically ventilation, how do we ventilate the patients? What vasopressors do we use? Is steroids indicated or not? What is the blood triggers? And what targets of glucose we keep in our ICUs? So let's see. So now to start, the most important principle, the sepsis principle, is like all other diseases, like myocardial infarction, like diabetic ketoacidosis. These are medical emergencies, right? So sepsis and septic shocks are also medical emergencies, and we recommend that treatment resuscitation should begin immediately. So they have mentioned it very clearly, and we should remember that sepsis is a medical emergency, and we should not delay the treatment for these patients. So again, if we flash back, from where we have evolved is, again, I told you about the Rivers et al. So that trial came into being in 2001. So it was end goal directed therapy. So what he did was, he had made certain protocols that needs to be fulfilled. So these were called as goals that needs to be fulfilled. So the goals were maintaining CVP of 8 to 12, mean arterial pressure of more than 65, maintaining a good urine output. By good urine output, we mean a urine output of more than 0.5 mils per kg per hour, SCVO2 of 70, more than 70%, lactate normalization. And if we do this, there was significant reduction in mortality. Reduction of mortality from 46% fell down to 34%, and number needed to treat was 8. So this was a revolutionary trial that time that reduced the mortality for the first time. This was the gentleman that conducted that trial, and it was done in November 2001. And we have already discussed these were the goals that he kept: maintaining a CVP of 8 to 12, mean arterial pressure, SCVO2, because we used to use central line that time. And also the blood trigger was 10 grams at that time. And there was significant reduction in mortality. And it's the same thing that this trial was incorporated in surviving sepsis guideline as well. The CVP, mean arterial pressure, urine output, and SCVO2. So this was the significance of this trial. So the recommendations again changed after this, and the recommendations of fluid was liberal, because he had given liberal fluids, and the fluid that we used to need to give was 30 mils per kg of crystalloids. So we divide the era of fluid management as pre-EGDT era or post-EGDT era. So pre-EGDT era, we were very conservative regarding fluids, and post-EGDT era, after the rivers at all, we became very liberal regarding the fluids. Now, after that, we thought we have achieved control over sepsis. Then there was 3 trials that came: the process, the ARISE trial, and the PROMISE trial, and the triology. So what they said was, they did not detect a significant reduction in sepsis mortality with the use of EGDT compared to usual care. So they said if we use a usual care and we don't follow the set of protocols given by EGDT, there was no mortality benefit. And in intention needed to treat analysis also, PROMISE found that there was no significant mortality benefit between EGDT and usual care. And the meta-analysis, the PRISM, also said the same thing. So, should we go back before the pre-EGDT era of conservative, or should we still stick around to reverse what he said of liberal fluid therapy? So there were certain caveats or limitations of process, ARISE, and PROMISE that we need to see. So one very important thing is the overall management over the years, over the last 1.5 decades, have already changed. We were giving antibiotics early, we were giving fluids early, and we started 30 mils per kg early. And so we need to be very careful about over-interpreting the results in areas where the paradigm is still not valid. And to conclude this part is, the reverse work was very, very useful, as it provided us to construct and how to understand resuscitation. That is most important. We have to give antibiotics early. We have to correct hypovolemia, restore perfusion, and in some cases, little more may be required. And these concepts that were given in 2001, in 2023, they are equally valid or more valid. So they are equally important as of now as well. Now the resuscitation goals have changed after these 3 trials. So we are in the surviving bundles that they have given. So we are not using CVP now, because we are not putting central line in all the patients. And also SCVO2 values we are not looking at. So what now we are looking at is a mean arterial pressure of more than 65, maintaining a good urine output of more than 0.5 mils per kg per hour. And also, if we have ABG, we look for lactate normalization as well. So these are the goals right now we look in patients with sepsis. Now moving on to next thing, that is the fluid resuscitation. So resuscitation from sepsis-induced hypoperfusion, we start fluid with 30 mils per kg of intravenous crystalloid fluids that needs to be given within the first 3 hours. So it is a strong recommendation now. So we have to use balanced salt solution, that is crystalloids, and starting at 30 mils per kg. And following initial assessment, we have to periodically assess if the patient requires more fluid or not. So this is what they have told. Start with 30 mils per kg, but do assess periodically. Just don't overload the patient with fluids. So the initial target of MAP is 65, as we have discussed, and it is again a strong recommendation, and guiding resuscitation to normalized lactate is still present. So if the lactate is higher, it means that there is hypoperfusion. So guiding fluid based on lactate resuscitation is still there. Although it's a weak recommendation. So now what new has come up in 2021 guidelines is re-emergence of capillary refill time. This simple bedtime test is very, very useful and can be used to guide resuscitation as an adjunct to the other measures of perfusion. So in the absence, if we are working in a peripheral center where we don't have advanced monitoring, a simple test of capillary refill by branching your index finger or thumb, and if it refills within 2 seconds, we know the perfusion is adequate. And if it is beyond 2 seconds, we know the perfusion is lacking and patient might be in sepsis or septic shock. And this was validated in a very, very important and very famous Andromeda shock trial as well, where they compared lactate normalization vis-a-vis capillary refill time. So they found out that CRT or capillary refill time was equally important or equally effective as lactate normalization. So fluids, what to give? So as we see, choice of fluid resuscitation has to be very wisely done. So crystalloids we have discussed is the fluid of choice. Yes, we can consider albumin once we have already loaded the patient with crystalloids, but there is a big no-no to hydroxyethyl starch that we should not use because of the higher incidence of renal replacement therapy, and it has been proved in many trials as well. So no, big no to other colloids other than albumin. So once we give fluids, how to assess fluid status of the patient? I did touch about the dynamic parameters that we need to see. So in ICUs now, in every ICU standard is looking at the dynamic parameters rather than the static parameters. So by dynamic parameters, we mean the variability of the intra-IVC inferior vena cava, that we call it as IVC extensibility or the collapsibility index. A very simple test is the passive neck raising test, where we just raise the legs of the patient, and it is a autologous transfusion of 300 ml, and we look at the cardiac output by a echo probe. Then fluid challenge against stroke volume, and if we have advanced monitors, we also look at the pulse pressure variation or stroke volume variation. So these are the dynamic parameters that we normally see in the ICU. So what about cultures? The patient is in sepsis. We need to send cultures of this patient, right? So we need to send appropriate cultures. So by appropriate, we mean that they should be obtained before starting antimicrobial therapy in patients with suspected sepsis or septic shock, if doing so results in no substantial delay. We should understand that treatment should not delay just because we have to withdraw cultures. But ideal scenario is to take cultures before starting antibiotics and from the appropriate sites. So when to start? So now we are pretty clear that the antibiotics needs to be given immediately. First they had mentioned up till 3 hours, but why wait till even 3 hours? So it should be given immediately, and if there is delay, maximum it should be given ideally within 1 hour, because again time is tissue. So if we are delaying, there is increased mortality. It has been proven in all the trials. 1 hour delay in starting antibiotic, the mortality increases by 2%. So we should not wait. So what antimicrobial therapy we should give? So if the patient is in high risk of sepsis or septic shock, initially they have recommended 1. But if the risk is high, we can start 2 antimicrobial therapy with gram-negative cover if we think that the patient is in gram-negative infection. In the same way, now in 2021 guidelines, for the first time, they have clearly said that if the risk factors are there for an MRSA infection, we can start with empirical therapy with MRSA. Also, if the patient is in high risk of fungal infection, we should start antifungal empirically also if the patient risk is high. So coming on, how to initiate our therapy, how to de-escalate the antibiotics. Very important test is prolactin test that we normally do, PCT levels. So should we do it to start antibiotics? Answer probably still is no. There is no evidence that suggests that we should use PCT levels to start antibiotics. So where the PCT rules come, where the evidence is prolactin can be used to discontinue antibiotics, empirical antibiotics, once the patient has started improving from sepsis. So if the PCT levels are coming down, so we can definitely go down our antibiotics. This is the current evidence for prolactin use. So moving on, guidelines recommend against use of antibiotics where we are just suspecting an inflammatory state and that is of non-infectious origin. For example, a patient with severe pancreatitis or a burn. In initial stages, the patient just has inflammation. There is no infection. So we should not use antibiotics in such cases. So just the crux or summary that this table I have taken from the Surviving Sepsis 2021 guidelines that we have already discussed. Again, the same thing. Administer antibiotic immediately. This is the take home from this antibiotic thing. Ideally within 1 hour. But if the patient is sepsis and shock is not present, so we can still take up to 3 hours, but provided there is no shock and patient is stable. And if you're looking for a source of infection. Now, source control. If patient has sepsis, there will definitely be source. And if we are just giving antibiotics without controlling the source, that will not solve their purpose. The source control is very important. An emergent source control should be identified or excluded as rapidly as possible in patient with sepsis. For example, a source that can only be removed by surgery, patient should immediately be taken for surgery. And for example, a patient who has intravascular devices, and that is a long-standing or maybe a CKD patient with a dialysis catheter, and you know that site is infected, and you know that is the source of infection, that should immediately be removed. In our ICUs for central line also, we have certain criteria we remove if there are signs of infection. Even we try to remove all the invasive lines as soon as possible because these all are potential source for sepsis. Now talking about vasopressors, we all are very fond of vasopressors. The moment the blood pressure drops down, we start vasopressors. But which vasopressors to use? Norepinephrine now has been proven beyond doubt since 2016 that norepinephrine is the first vasopressor of choice. And it has a very strong recommendation now. And if the blood pressure maps are not being maintained, now we start with vasopressin as well. Then still there are maps are not maintained. The last we start is epinephrine, but there are certain set of patients only where we start epinephrine because we know that epinephrine is arrhythmogenic. Patient can land in arrhythmias as well. So these are the recommendations for vasopressors. Dopamine for renal doses is big no-no now. So dopamine should not be used for patients for renal to improve the renal perfusion. And dopamine has only certain set of criteria where you should use dopamine. That is, there is an absolute or relative bradycardia, and that is the only criteria. Otherwise, like epinephrine, dopamine can cause tachyarrhythmias, and they are more harmful rather than being beneficial. So this is the crux. This is the summary for the vasopressors. We have discussed this. Norepinephrine is the first choice. Then target map of 65. So one thing now they have included in 21 is even if you don't have central line, we can start vasopressors from the peripheral line as well. So although we need central line because they are highly osmolar and but initially we can start vasopressors from peripheral line, and the dose if it is increases we need to take central line. And we do consider adding a vasopressin. And for patients with cardiac dysfunction, then we use inotropes, that is dobutamine. Now mechanical ventilation. So there are ARDS net trial has proved beyond doubt in 2001 that we now go for low tidal volumes rather than high tidal volumes. So they have proven to be mortality benefit. And we use higher PEEPs than lower PEEP in adult patients with sepsis-induced moderate or severe ARDS. So what are the changes now? Now we all have become big fan of prone positioning. After the ProSeva trial, now prone position is highly recommended. So even in COVID time, we saw that prone position was highly recommended. Now we recommend even awake proning. So proning has its own benefit. It is a separate class altogether, but we highly recommend that prone positioning should be initiated if patient is landing up in moderate or severe ARDS. And also there is a great evidence for high flow nasal oxygen over non-invasive ventilation. The Florelli trial has proved that HFNO, high flow nasal oxygenation, is in some cases superior to non-invasive ventilation. And we all have now HFNOs in our ICUs as well. Steroids, corticosteroids. So clear-cut recommendations now of use of corticosteroids in patient with sepsis and even starting corticosteroids early. So what is a dose? 200 milligram per day. So if you have infusion pumps with you, give it as infusion or can be given as 50 milligram over 6 hours. So this has been proven in all the trials. So important trials that validated this was adrenal approaches and vanished trials that validated the use of hydrocortisone in patient with sepsis. Blood product administration. So one thing has changed. River et al. At his time has used a trigger of 10. But now we are more towards restrictive rather than liberal therapy. The cutoff now what we have kept in our IC is 7 grams. And this has been proved in strict trial. So these are the independent trials on blood transfusion and they have proved that restrictive therapy is better than the liberal therapy. Except for patients who are in active myocardial infarction or ACS, where the trigger is slightly higher, a 9 or 10 gram trigger we keep in patients with ACS or myocardial ischemia. Now talking about the glucose control, a protocolized approach we follow for glucose and the target we keep is between 140 to 180. We don't keep a low target because of the risk of hypoglycemia, and we all know that hypoglycemia is more harmful than hyperglycemia. So targets are 140 to 180, and in 2021 guidelines also they have mentioned the targets as the same. And we start with insulin therapy in patients in ICU if the sugars are beyond 180 milligram per deciliter. Role of vitamin C. We have all used vitamin C in COVID. In liberal doses, vitamin C was used. What is the evidence? Sadly, the evidence is against vitamin C. So vitamin C should not be used. 7 randomized controlled trials have been conducted in the last 3-4 years, and all have seen that there is no mortality benefit for the use of vitamin C. We have used in very, very high doses after the Maverick trial that suggested of use of vitamin C of 3 grams. So, but the evidence is not now against vitamin C. Nutrition. There is a saying that if you have gut, have it, you use it, because there are chances of gut translocation if you don't use your gut. So yes, early enteral nutrition significantly reduces mortality in patients with sepsis. And once the patient is admitted, we need to start orally or enterally within 48 to 72 hours of ICU admission. And enteral nutrition is always favored now because of the obvious risk of gut translocation if we don't use gut. Venous thromboembolism. All critically ill patients are prone for DVT and pulmonary embolism. So 2016 and 2021 guidelines joint recommend venous thromboembolism prophylaxis. And for that, we use no molecular weight heparin like enoxaparin or a deltaparin, or it should be used in all these patients because they are all prone for venous thromboembolism. So just to conclude, what we normally do in our ICU is we give a fast hug to all the patients at least once a day. So by fast hug, we mean is we look after the feeding, we look after their analgesia, whether when the patient is he's on ventilator, whether the patient is adequately sedated, patient is calm, comfortable or not. We look for the thromboembolic prevention. We keep the head end of the patient elevated to 30 to 45 degrees unless there is a contraindication. We look for the stress ulcer prophylaxis. And as we have discussed, we also take care of the sugars, and we keep within the range that is 140 to 180 milligram per deciliter. So yes, fast hug we give to all the patients in our ICUs. And just to summarize it, surviving sepsis guidelines bring together the most contemporary knowledge and refinement in treatment of sepsis. But we need to remember a tool is as good as the user. We should remember these guidelines, but we should also know how to use them. So if we can't use them properly, there is no fun of having these guidelines. So this is my take home. And if you suspect a sepsis and you save a life, it is very gratifying feeling once you know that patient walks back out of your ICU once he's in septic or sepsis or septic shock. Thank you and greetings from HBCH and RC, New Chandigarh, which was recently last year and then inaugurated by Prime Minister Narendra Modi. Thank you all.
Dr. Harsimran, it was really a wonderful presentation, very well prepared. and very informative. And I'm sure all people who are dealing with critical patients in ICUs especially, and even the people who are dealing with such patients in primary healthcare, I mean community health centers or civil hospitals, they may benefit. So I'll like all the medical officers, the junior residents, the senior residents to watch this video repeatedly rather, to have a good idea how to manage sepsis. So thanks a lot. And so with this, we come to the end of the session. And please take care and happy doctor. Thanks.
Thank you for having me here. Thank you so much.